Thank you everyone for joining the Minnesota HIMSS webinar on reopening in a post-pandemic world. We will be recording this event and making this available to all of our Minnesota HIMSS members. If you would like to be a speaker or sponsor for a future webinar event, please reach out to us via our webpage, mn.himschapter.org. We will do a Q&A at the end of the event. If you have any questions that you would like answered, please type those in the questions section of GoToWebinar, and we will review those at the end of the presentation. I am pleased to introduce Mike Stack today, who will kick us off on our webinar and introduce our speakers. Mike lives in the Minneapolis-St. Paul area and manages the Midwest region for Optum. He has been with Optum for the past 6 years, the first 3 years managing the business development team for Optum's innovation organization, and the last 3 years in his current role as VP of Sales. Prior to Optum, Mike led the sales team in a business-to-consumer CRM marketplace, focusing on healthcare payer markets, specifically United Healthcare. Mike has a BS in accounting from the University of Wisconsin. Thank you, Mike, for participating in today's webinar.
Thank you, Rebecca, and I'm really happy and excited to be here and introduce a couple of my colleagues on the webinar here today. As Rebecca indicated, we are going to be presenting the reopening in a post-pandemic world. I think it's safe to say that we have been through in the last 3 months a very unusual time in our country and frankly in virtually every region of the country, not just the COVID virus, but the social unrest that we've faced and that I think all of you are probably facing as well as we kind of move through the pandemic, as well as other things that are creating new and unusual circumstances. So I've asked a couple of our people, and just I'll give you let me just give you a little bit of background. Optum, about 1.5 years ago, and I have responsibility for sales in the upper Midwest, which we define as Missouri to Minnesota and the Dakotas, for the hospital marketplace. So all of the Optum solutions, and more importantly, and I think for today's conversation, I also have responsibility for the advisory board research memberships. So I've asked a couple of my colleagues, Rob Nation and Garrett Jones, to join us today and talk specifically about reopening and use some of the research that comes out of the advisory board to sort of evidence the conversation. We want to make this very much a your meeting, so please send the questions in. And we'll address them. But I think they put together some information here that I think will be very helpful, and frankly also give you the sort of variables that are in the marketplace right now. Because again, I think we're all dealing with something that we've never seen before. Number one, and two, we don't know all of the answers as we move into the second half of 2020. So with that said, let me introduce Rob Nation first. Rob's been with Optum for the past 2 years. He's an actuarial, so he comes with that kind of background, and he works primarily with providers, although he has worked with payers in the past. And he's a leader in our advisory services organization, and again backed up with a lot of the advisory board research. Also joining Rob is Garrett Jones, who's been with Optum for 3 years, also part of our advisory services. I'm going to let them, they can do a lot better justice of their own background and stuff. But I'll turn it over to Rob, who will turn it over to Garrett, and we'll jump into this discussion here. And again, feel free to send your questions into Rebecca, and we'll make sure that at the end, I think we're going to talk for probably about 40 or 45 minutes and then spend the balance of the time answering questions that you send in. So your meeting, and we certainly want to be able to, address your specific concerns as well. So with that, Rob, can I ask you to introduce yourself, please?
Great. Yeah, this is Rob Nation. I'm born and raised in St. Louis, but lived in DC for several years, and now actually for the last 4 years, my wife and kids and I have moved to California. So I went to school at Drake University, so just down the road from most of you all, a few hours. So I had a lot of friends from Minnesota. So really excited to talk to you all. And I guess just maybe like an opening word or remark. This project has been fascinating. I mean, I think people have lots of feelings about COVID, and I think one of the challenges with COVID is that, in a good way, people have access to a lot of data and information, and I think that's what we're going to talk about. But one of the challenges when the broad population has access to a ton of information is that you've got to make sense of it. And we've tried to, and I think our conversation today is really about how do you make sense of so much information? How do you sort through the information that's good and bad? And how do you have confidence in the things that you know, and the things that you know that you maybe don't know? And what have we learned over the past, say, 3 months intensively about COVID? So I know many people probably have lots of thoughts and opinions and persuasions and just overall gut feeling about COVID. And a lot of people probably have general COVID fatigue at this point from both the quarantine aspect of it, the social aspect of it, as well as just the daily discussions about COVID. But anyways, we think we have an interesting discussion, and I think particularly within the healthcare analytics field, this is a really interesting to take a look back, but also taking a look forward at what do we think is happening next. So with that said, Garrett's going to take us through the next set of material, and then I'll be talking towards the middle of our presentation. But with that said, Garrett, you want to take it away?
Absolutely, Rob. Thank you for that. Everybody, nice to be with you today. My name is Garrett Jones. As Mike said, I've been with Optum Advisory Services for 3 years. I've been working in the healthcare consulting field for 13 plus, and primarily worked on the provider side of that, although in the last couple of years working as part of Optum Advisory Services have worked a lot within the broader United Health Group enterprise, consulting with our UHC organization within UHG, largely on a lot of strategic initiatives, and lately around digital health, which is particularly timely within the context of what we're talking about today with COVID-19 and telehealth and all of the needs and consumer preferences for those modalities. So I'm really happy to be with you talking about this topic today. Wanted to also say, it's great to be with you in this landmark time in our nation and our world. And I want to thank each and every one of you for being part of the system that provides the frontline care to people in our country who have been affected by this pandemic. And I know that we would not be anywhere without you. So I just want to take the opportunity to express my appreciation on behalf of Optum for everything that you've done to be part of this and help make the lives better for everybody who've been impacted. So with that, we will jump into the agenda for today. What we'll be covering, as Rob mentioned in his opening, we have I think a compelling and interesting and thought-provoking talk for you all today. We want to review where we've been, what we've been through, and where we might be headed in our current reality, and then talk a little bit about why it's challenging to find our reopening window. And those challenges are unique to markets, to organizations, and specifically unique to timing. Rob's going to explore some of the nuances of that. And then in the third final section, before we take questions, we're going to talk about what it means to reopen and some of the approaches and methodologies that we've been working with our clients to help them design and develop as they develop specific plans for their organizations and in their own markets with their partners to really make sure that reopening is successful and, most importantly, safe for them, their employees, and their communities. So I'll start off first with really understanding and just level setting with our current reality. One thing we like to talk about before we review where we've been, where we are, and where we're headed is what do we think about when we when we've developed the scenarios that will shape our future. And as strategists, Rob being strategically oriented in his view of the world, but also an actuary, me being on the strategy team as a consultant in Optum Advisory Services, we have to develop assumptions as we look forward in the future, and we think about how do we make informed decisions using data, but also informed decisions using things we don't know about yet in order to develop a plan about the future. And one thing that we do in doing that is we create assumptions, and we use those assumptions to inform those decisions. And in developing this information and developing our plans with our clients, there are 10 things that have kind of solidified for us. And as we developed these back in April, as we started working with clients around planning for reopening and planning for the next surge and planning for even future and subsequent surges and monitoring beyond this initial curve, we developed these 10 set of assumptions. And as we've moved forward in time, it's amazing how so many of them have held true and have become realized. And so I wanted to share these as we open up this talk today. I'm not going to read each and every one of them to you, and of course you all have them as part of the presentation, I believe, that was uploaded. But you'll see that so many of them are becoming real. I think some standouts for me that I really want to underscore, of course, is number one, that vaccine timeline continues to be the overwhelming kind of consensus that we're working on as an industry, that we will likely not have a viable vaccine for another 12 to 18 months. And in the meantime of that period, we will all be working in compromised situations, in less than ideal environments, in some states of socially distanced communities, trying to figure out how best to create trust, create safe practices, and attempt to operate as normal as possible given abnormal situations. So that's one that I think we've all kind of landed on, and there's consensus around. So just some assumptions to consider as you are thinking and working with colleagues and working with your communities, that you have to really incorporate into your planning decisions. One other thing that I think is another one that is been really important to our clients, it's been a pattern across all of the different conversations that we've been having, is number 10 actually, and that's despite pent-up demand, consumer response may lag as confidence needs to develop. So we've seen it in the hospitals that we work with, our partners. We've seen it within our own Optum Care partners within our Optum organization, within volumes. We've seen it anecdotally in the research that we do as an organization. Consumers have responded with some hesitancy, even in communities where restrictions have been loosened or lessened. And so what does this mean to pent-up demand, and what will this mean to the conditions of their diseases, and what will this mean ultimately to the health of these communities? And so these are all things that we're talking about with our clients, and helping them to think through how will they prioritize that demand, and what will that mean to their care management, to their service line strategy, and ultimately to their enterprise financial modeling. And all of these things we'll revisit later on in this presentation about and circle back to. But one thing I wanted to leave you with before we continue on in this presentation was other assumptions that you think we should be considering as not just an industry, but as consultants. Feel free to include in the chat applet. We take questions, and we also take additional feedback. So feel free to share those as well, and we can revisit those and try to incorporate those into the end of our session. So where we've been, what's happened, I think we all are pretty confident in knowing where we have been and what the initial surge looked like. But understanding the objectives of that, I think, are important to understanding the objectives of where a lot of markets are today. So those objectives were really about how do we utilize supply efficiently, how do we maximize that supply, specifically how do we maximize it given the constraints of it, and accommodating the surging demand within the constraints of that supply, and reducing the spread as much as possible. And that really comes into the social distancing and the measures that were kind of uniformly adopted across the nation. Where we're at for the most part today as a nation is really in that second pillar and transitioning into new normal. That quote, new normal, is intentional. Prioritizing demand is I think probably top of mind for most organizations. Not only just how do we prioritize demand, but how do we prioritize demand systematically? So we have to establish that new systemness in doing that. If we ourselves are one piece of the ecosystem that services that demand, if we don't have the partners to do that, it's tremendously hard to not just prioritize, but actually address and accommodate that demand in a way that's effective. Increasing in testing availability, which is unfortunately an issue still to this day and will continue potentially to be an issue. And we are somewhat limited in our ability to fix that as individual organizations and in this industry, and may continue to be a challenge as we continue on with waiting for the vaccine. And then maximizing surveillance. So this is really getting into how do we start to become a more real-time monitoring unit and purveyor of real-time community surveillance and knowledge, taking data that exists or being the broker and reporter of data that could potentially exist in the community to make informed decisions about what's happening to spread in our communities before it actually ends up in our hospital as hospitalizations and mortality. So it's a key part that we were trying to get our hands on in the initial surge, but now that for many of the markets that experienced that surge, the surge has dwindled and we're on the other side of the curve. We've been educating and working with those markets and those organizations who are leading in those markets to help them really think through how they might be proactive in doing that, because it is going to be important in really helping them to be a little bit more ahead of the next curve as it inevitably could happen again. And then that third pillar really is, when is that next surge going to happen in our market? So it's all about managing hotspots, directing those clinical and business operations accordingly, coordinating with public health in a more systematic way, in a more proactive way than we were able to maybe do in the first curve. And this fourth one is really important because we weren't able to do it in this first go around, is staying open while accommodating the surging demand. We think that likely there will probably be a need or a kind of demand to continue what is the new normal operations, even amidst potential hotspotting and surges. We might not have the quote unquote luxury of ceasing elective and otherwise normal healthcare operations and services with subsequent surges and waves that hit in the fall and otherwise. So really remaining open and staying open and continuing normal operations may be demanded and may be expected in the future, and repositioning assets accordingly to do all of that. So that's really kind of our position on where we think this is going, where we think the future, the near-term future lies with the future surges and the future waves. Some questions we want to leave you with as we enter into the next part of this presentation. The ones you see on the screen are relatively tactical, operational, financial. Ones that I'm a little more interested in, what I think are a little more compelling for strategic-oriented folks. They're a little more on the macro side of things. Will COVID COVID-19? Will this period of time that we're in and what it has kind of done to shake in our healthcare system, will it stimulate or depress value-based care as we know it? That's one that I and others and my team, and I know others in the industry are talking about. It's an interesting one. I think we all are scratching our head trying to figure out, is there a right answer and what those answers might be. And so that's one, would love this group's thoughts on that one. So as we're going through our presentation, maybe keep that in your pocket and think about that one. Another one is, what's going to happen to mergers and acquisitions? What will happen to our facilities given the financial outlook and struggles of the system that has happened this year? So the activity in the M&A space, how will that respond? What will that look like? These are two questions that I find particularly interesting and particularly timely, given what's happening in addition to what's on your screen, that are a little bit more tactical in nature. So with that, Rob, I'm going to hand it over to you as you talk about the challenges of finding your reopening window.
Thank you, Garrett. Appreciate it. So I think Garrett talked a lot about, a lot of the big questions that we think about, from a business standpoint during this time. As an actuary, I'll probably be a little bit more technical in my discussion, although I'll try to keep numbers out of our presentation. I think one thing I would just like to say, this is the way I've been thinking about it, is, for me, I felt like for the last 3 months, all day I've been thinking about modeling COVID. How do we use data to understand COVID better across different markets, within different markets, within micro markets, rural versus urban? How does weather impact COVID? How do protests impact COVID? What's the distribution of ages and gender? And how does it impact, how do mortalities flow through those different functions? How does social determinants of health? There's all these different data points that we can use to think about COVID, and there's correlations that can be dug up through all those different data points. And it's, from an actuarial standpoint, from an analytics standpoint, it's fascinating. The sad thing is it's also very, very real for people at a personal level. And I think one just broad observation that I made is that, as I've been looking at this stuff professionally, what I would experience is, I put in my day, and then I click on the news and I see there's a whole bunch of other stories from the media that were kind of covering something different than what I've been looking at professionally all day through different data sources, right? And my wife would ask me frequently, well, what's happening with COVID? Is it getting better? What are you seeing in the data? And the best analogy that I can make is that it's like asking me what the weather is like in the U.S. at a given point. And I think, there's a lot of questions. Well, what do you mean about the weather, right? Are you talking about the humidity, the temperature? Are you talking about the cloud coverage? Is it raining? Are there thunderstorms? What's the barometric pressure, right? There's all these different questions that really can kind of drive at what's the weather. And I think it's similar with COVID. And I think we've been trying to make sense about, with all this information and some of the data that's available to us, there's been more data available at a more granular level as time goes on. And so, as this slide asks, when do you open? How do you open a business, a healthcare business, and not risk? You don't want to risk financial viability long term, obviously, and you also don't want to bring people in and increase the risk of infection through COVID. So, that's kind of what we'll be talking about today. We've built several models that help to try to answer some of these questions. And I would say, my personal view on all of this is, how do you use data, or sort of the way I phrase it, big picture, is how do you use data to, if you're a provider, how do you use data to be bullish about bringing as many people in safely in a COVID environment, right? And so And then once you have data that can help answer some of those questions, then you can figure out what's the strategy to do that in a safe manner or in a safer manner, whether that's using different sites of care, whether that's shifting some of your practice patterns, putting in place obviously new protocols for safety and cleaning and things like that. So these are all things that I think make this an interesting time, but also a challenging time to work. Maybe on the next slide, we'll get into that a little more and talk about some of the models that we use. So big picture, right? Like I said, in some of this, I think a lot of this is probably maybe a month or so too late, right? Because we were probably having this specific conversation more about a month ago, right? At this point, people are generally trying to get people back in the doors and increase those volumes. But obviously, this slide just really reiterates the fact that if you bring people in too soon, there's a series of risks that you take in. And if you bring them too late, there's also another series of risks, and both need to be balanced. And I think, at least this is my opinion, is that if you look at media coverage, for instance, I would say I've certainly seen examples where the media has been far too cavalier about COVID and the risk of COVID. I've also seen many examples where I've seen far too much panic. And I think, again, the challenge is, especially in this continuum of when do you go in too early or do you go in too late? And there are risks on both sides. How do you pick the right time, and how do you use data analytics to inform when to move in, and then the inherent risks that come along with those choices. Next slide, please. Okay, so a couple, kind of break this down a little bit. We've been thinking about three primary pillars or areas that we think about when we look at data, right? So, and some of these we can control, and some of these we can't. And some of these areas we have more information at a really granular level, and some of them we don't. And then we've also got areas where we have the information, but we've seen that it's not always as it's complete, but we also don't know that we're confident in the validity of that data day over day. And I guess what I'm referring to more acutely is, you've got COVID tracking projects, you've got the New York Times, you've got USA Facts. These are all different sources of data. I could list probably 5 or 6 others that compile data, but they're really a compiler of data. They're not the original source. And so, you've got to, when you evaluate the problem, you have to really understand what is my source of data and what is their source of data, and do we trust that? And I think that's been one of the challenges with COVID in general. But in this slide we're talking about public policy, right? Most states are now opening up or have opened up, and now we're trying to understand, well, what's happening in Arizona, what's happening in Oklahoma, what's going to happen in these different states where things have been a little bit more lax or are on the more lax side of public policy, and how is that impacting infections. We look at what we call a risk assessment, which is some static information that we just know about a population, right? New York, obviously, incredibly dense population, tons of public transit, and so there's obviously a lot of inherent risks that we know about that specific market. We also look at infection trends, and we've all become sort of overnight epidemiologists, and we now use words commonly like R naught. R naught is a rate of transmission of COVID from one person who has it to others. And so a higher R naught factor, just R naught value, means that you're spreading it more. More people are spreading it to other people. And we've been able to witness this in different markets across the country by looking at mortality rates, case counts. And so we've developed some risk assessment tools to say, looking at social determinants of health, transportation scores, and historical COVID infection patterns to understand the inherent riskiness of the population. We've also looked at how quickly does a population react have they reacted to social distancing measures that have been put in place? And the third thing is kind of like, what are the things that we're looking at in the future that will help us to understand what's happening? And I will say, I'll just kind of highlight one challenge with that, is that some of the data that we found, say in March and April, which was incredibly useful for us at that time and more reliable for us then, has become less it's still important, but it's less prescient in terms of understanding what's going to happen in the future. And so that's another evolving challenge that we face with COVID. And so, our general approach, and I think I'll probably go to the next slide and kind of get into this, is to realize that one analytics tool doesn't solve every need. And so we really have kind of a host of different tools to help evaluate the problem. Really this slide highlights what I think is likely happening in America right now. You saw a first initial wave, and then in different markets, depending on a ton of different factors, up to and including prevalence and the intensity of protests, for instance. That's something that we had no idea that there would be these protests that have essentially caused mass gathering when otherwise that was not taking place. So, for instance, that's one example where we might expect to see a large wave. And I think there are some places, Arizona maybe is one, where we're starting to see a second wave that maybe even bigger than the first. And maybe it wasn't even a wave, maybe it just kind of continued to grow because the initial COVID infections weren't that high. Other markets we're seeing sort of, there's been the number of infected has actually decreased. And so there are less people who are infected and then less people who can then infect others. So we're seeing sort of and expecting more of an oscillating wave. And the third, high level scenario that we sort of see is, maybe if you're in a market where you really tamp down the infections, they're very low per capita, then you might only see some small hotspots that likely are not going to put too much undue strain and burden on the overall healthcare system. So these are just some general scenarios. The way we look at it is our tools to model the initial surge. In general, we use our team used actual mortality counts on a daily basis at a county level basis to model out what we thought of as the initial surge of COVID infections. And the reason we did that is because we found that case counts by market were largely unreliable, because we understood that generally cases were dependent upon testing, and testing varied wildly. And that's why if you look at things like case fatality ratios, so for instance, how many cases are there relative to the number of deaths, if you look at those ratios market by market, they vary wildly, which tells me that likely some markets are just testing much better than others. And this is even more true 2 to 3 months ago when testing was less prevalent. So, that was one of the things that we learned, is that using mortality was a much better indicator of COVID infections. And what we did is we basically modeled backwards to say, if there was a death today, we realized there were probably maybe 100 infections or, in the past. And we basically applied age bands, to those ratios, and then basically backwards projected and then forward projected what we think were actual infections in a given market. A little bit confusing, but we found that methodology actually was the best. I mean, we then compared that to other leading academic models out there. A lot of people have their favorite. We used University of Washington's IHME model quite a bit, and use that as a validation point. My point is, where we are now, middle of June, a lot of these second waves have been emerging, and now we have more information. And so, where deaths were really useful in the first surge, they're not as useful, going forward, because deaths are naturally a lagging indicator of COVID. So when we look at the spectrum of data that's available, we see that there are some leading and lagging indicators. Some leading indicators might be mobility data, how far are cell phones moving, and how much can we track that. There's moving from leading indicators to lagging. You've got some symptom trackers out there, people who are taking thermometers, and there's some data around that. There's survey data. There's Google search information. So if you've got a bunch of people in a specific market who are searching for COVID symptoms, we probably think that might be an indication that there are going to be hospitalizations the next week or two, because there's been a surge of those searches, right? Obviously, then we have testing data, we have case data, hospitalization data, and finally we have death data, which is the most lagging indicator. And so as we build surveillance tools, we keep these lags in mind, and that's one of the challenges in terms of building tools that really focus that forecast what's going to happen in the future. So the next slide, I think we can kind of talk about that. We've talked a little bit about this already. There's different places to enter the market, and I think in general, our general feeling was to be not swayed by anything political, really, but really be data oriented in terms of what we're seeing with the information. And so right now we use kind of a host of different tools. Like I said, we had an initial supply demand model that kind of modeled the first surge of COVID. We've got it's kind of a combination of a Monte Carlo simulation, so we can actually simulate different scenarios. And then we also have a deterministic model where we say, we think this is going to happen. We think this specific scenario is going to happen, where you've got R0 values that are going to take off in, say June, or maybe you think that they're going to take off in the fall. And so we basically are able to model all these things sort of from a planning perspective. And I think our perspective is, if a hospital CEO comes to us and says, how do I enter this market? How do I bring patients back as quickly as possible, because I need to financially? How do I do that confidently? And our general approach is, well, you need to have a good surveillance methodology. You need to have the most current information for your market that's available, and we try to aggregate that information. But you also have to be able to plan and say, what if this scenario took place? What do we know about your specific market that says you're right for a second wave that might be even worse than the first? Or what do we know about your market that says that's likely not going to be the case? We've got herd immunity calculations, things like that. So there's a lot of different metrics that we use, and none of them are a single silver bullet. But we find that by putting more of these pieces together, you get a more full picture of what we think is actually happening in the market. So I think with that, we'll kind of we've got a few more slides that we'll talk about, and we'll take some questions.
Yeah. Thank you, Rob. Really fascinating to see how we kind of model the different waves and the different kind of ribbons within them. We'll talk relatively tactically before we get into some of the questions that you all have saved for us for the end. This last section is really about approaching reopening in a method that's gradual and sequentially. We've developed a framework that includes really 5 different prongs to it: assessing where the market is in recovery, prioritizing where to resume and when to resume activities, not going at it alone, so really understanding what partners we need to do that, becoming more of a public health entity, really leaning in on public health, given that it is now more than ever part of the job as a hospital and health system. And the last one, developing a new enterprise financial model, given the changes in payer mix and the changes in modalities that are going to happen, transitions to telehealth and projections of revenue and changes to cost structure that are inevitably going to happen, that have happened over this year. So with that, I'm going to hand it back over to Rob as he talks a little bit about how to assess where the market is in recovery.
Great. So again, we've got a few different things that we've talked about here. So I have the pleasure of working day in, day out with an epidemiologist who's been really tremendous to work with. So, we look at a handful of, one of the things we try to understand is ultimately, I said a lot of words, I said a lot of different data points, but at the end of the day, we want to understand particularly the strain on the healthcare market, right? The healthcare system in a particular location. And, looking at specifically, beds, both med-surg beds as well as ICU beds and ventilator usage. And we now have a pretty good picture, at least on those types of trends, and as well as the age and gender impacts on the usage for those. I think one of the things that people have been startled by when you actually look at the graphs is just how much more severe COVID is for our more senior populations. And also that it impacts men more than women, right? So there's all these different things that we've learned. The other thing that we look at is, like I said, some of the specific risk correlated metrics within at a county level. So we've been bringing in data for that, as I mentioned. We've been looking. It's amazing to see how much new information we've been able to kind of roll up into our tool. And I think that's really a credit, not really about Optum or anything, but really just a credit to the overall, analytics community, because I think we've seen people make readily available new information publicly, which has been really great. And I think that's actually something I'm actually really curious about post-COVID is now that we've seen how to combine new pieces of information, will that lead to broader innovations, even beyond, COVID in particular, but within the healthcare sector. I think that's next slide. I think Garrett.
Yeah. So as we look at prioritizing how to resume activities, it's really thinking about it a little bit holistically and not just the services, but how do we look at our overhead and administrative costs, and then getting into clinical services, and then also our care management and our population health programs. How do we relaunch those? We have to understand, how much of our tolerance is for resetting the overhead costs and our percent, what our benchmarks were previously, what our benchmarks need to be in the future for us to remain financially viable given revenue hits and kind of what that enterprise outlook will be as an organization. So really understanding how our new cost structure will be is something that we are assisting organizations through at the moment, and really cascading those cost reductions by departments in a way that makes sense. So the clinical services reopening and expansion, making sure that that is done in synchronization with the partners in your community, using virtual care to support and augment those services where needed. So being very, very, very thoughtful and very intentional about the use of digital health capabilities to expand the capabilities within your clinical services model. And then on care management and the relaunch of care management, it's really understanding not just, how do we kind of sync up care management to manage, not just from a case management standpoint, the inpatient stay, but also broadly care management across the ambulatory enterprise, and thinking through how the long-term, assets come into play, the referral patterns and increasing, home health and telehealth and SNFs coverage, to really understand how we can kind of stir up those relationships in the long-term network, so that when eventually other surges and subsequent surges happen, we do have a little bit more of a coordinated effort, and we know exactly how we're going to work with those organizations, which organizations we're going to refer to in the times when we have high disease and infection rates versus those which are more like normal routine expected care. So all of that will be part of our like package of services that we would think through in prioritization and resuming of normal activities. Rob's going to walk us through about how we think about key partners and not going at this alone.
Thanks. Yeah, and I'll be relatively brief here. I know we're coming up on time, and I want to save some time for questions. But I think one of the things that I think could be a good opportunity coming out of COVID is the enhanced demand for building partnerships within your local market. I live in Los Angeles. We've got a ton of there's so much healthcare in Los Angeles. We've got 3 huge AMCs just here, and we've got more in Orange County. So it's a big market, obviously. But there's so many different. There's a ton of people, and those people need to get. Then you got to build those relationships with your SNFs as well. And I think if I think a little bit outside of COVID in particular, this is obviously very important from the standpoint of overall value-based care, building partnerships that you can rely on, and building partnerships that have a common value as you do. So I think this is actually a good opportunity to reinforce those partnerships and build new ones where it makes sense. Another part of that kind of goes hand in hand with that is referral patterns and understanding where patients go, where they like to go, where they live, where they work, and as well as what's the best care for patients. And I think we're also seeing obviously new things like telehealth has become far more prevalent, which is great. I think in some ways COVID has sort of pushed that platform into our healthcare system in a far more material way. It's exciting to see how that might allow us to be more efficient as an overall healthcare system. And then finally, just managing inventory. Obviously, there's been a lot of discussion about this, making sure that not only you as a hospital, but also your partners have what they need to do their jobs and keep community safe. So what makes me, what I think about a lot is that, in March and April, for instance, in most parts of the country, we saw that there was a ton of capacity in the healthcare system in general because people didn't want to get COVID, and so they cleared out of the hospital in a lot of markets, and so there's a lot of room for COVID patients. What will be interesting is in, say, the fall, if there are resurgences in COVID, when patients are back in the hospital and more at likely more at a full capacity, particularly because of all the pent up demand. So, that's one of the things that I think will become a new challenge to face, in the coming months. So, Garrett?
Well, with that, Rebecca, we want to make sure that we do save time for questions. Our last 2 points, leaning in on public health and making sure that the enterprise is set up financially with a revised reset on the financial model. We'll have those slides, of course, available in the presentation. So we will pause on those and open up time for questions if there are any.
Thank you. Yes, if you have any questions, please type those into the question section of GoToWebinar. As you think about reopening in this post-pandemic world, and there's lots of data points that health systems can look at, what really can analytics tell us, and what can it not tell us, and what should really health systems be looking at for metrics in finding their window?
Yeah, great question. I think and probably hinted at this a little bit. I think there's been many times when people have sort of demanded answers and maybe been a little bit quick to rush to a conclusion. And that happens a lot, right? But I think it's happened a lot more with COVID, even because of the real urgency that this pandemic has caused. I think we found times where people wanted to jump to certain conclusions very quickly. And what we would say is, we've learned a lot of things that we don't know, right? There's a lot that we really don't know. A lot of people wanted to assume there's going to be a huge second wave. And I think we're already starting to see in some markets that's taking place, in some markets it's not, so far. And so, I would say in some ways it's given us a little bit less confidence in our ability to predict with specific accuracy. On the other hand, it's also made us more reliant upon the things that we do know, right? So, and another thing I guess I'll kind of highlight this. People have asked for, what's happening in a particular market. Well, and some people are tempted to only look at case counts, right? They'll just say, oh, cases are up or hospitalizations are up. We saw this the other day with Arizona. Somebody said, well, hospitalizations are up in Arizona. Well, when we looked into the data, what we actually found is that hospitalizations really aren't tremendously, new hospitalizations are not up, new admits are not up, but the length of stay has increased for a backlog of patients that were admitted, even a month ago. And so patients basically have not been getting out of the hospital, so the current census of patients has been higher. And so you have to look at all these different data points. You have, when we look at case counts, you have to also temper that with what the testing and positivity has been in a location. And oftentimes we don't have that at a county level. So those are some of the challenges that we've had. But what we've been encouraging our stakeholders that we've been working with to do is to really look at probably the main 5 things is look at cases, the most recent emerging trended, and oftentimes we'll look at, a 7-day rolling average. So you kind of normalize some of the bumps. But we look at cases, reported deaths, testing, positivity, and the patterns of new hospital admissions related to COVID. I think if you can actually look at those things all together, and not in one isolation, or not give too much credence to one specific data point, that's really key and critical.
Great, thank you. We have a couple of questions in here about safety and really feeling secure in this new normal. Maybe, how do we determine, or who really can determine when is it really safe for our employees to come back, and then when is it safe for us to fly again, or if we have a combination of employees that are in the office and maybe traveling at the same time, how do we manage that?
I don't know, Garrett, do you want to take that one? Some of that I can answer. I think some of that I don't know that either one of us is technically qualified to answer whether or not you should fly or not. I think in all things, precaution and erring on the side of caution is a better approach. That said, in the healthcare sector, I think, my mom's a nurse practitioner, and obviously she's been working, and so I think the challenge is to be as cautious as possible. And I think we have some new tools, right? Like I mentioned. And I don't know, Garrett, you want to take a stab?
Yeah, can you hear me, Rob?
Yeah, I can.
Are you able to hear me? Okay, great. I think my audio cut out for a second. I would agree that I think that we are we're in a little bit different of a position to answer this question than the analytics. But I do know that from a standpoint of our organization, Optum, of course, we have a very large provider network and practice that we are making decisions about how to return to work, how to do that safely. And I think the answer, and it may fall into the category of a little bit of a non-answer as well, but the idea is that decision is made kind of cross-functionally and multidisciplinary, and there's a team of people that is making those decisions that include clinical safety, quality, employees themselves, people from different roles, HR. I mean, the gamut of responsibilities are included in making those decisions. Legal compliance. So the point being is, I think every organization really has to look at each of the services that they provide, and from a in a health system standpoint. I see many of the hospitals and health systems that we work with, and especially in the community that I live in, which is Milwaukee, most of the health systems in this community have started to resume normal operations. They're starting elective surgeries. They're doing in-office visits. They've, of course, increased telehealth and have started to promote telehealth and virtual visits as much as possible, but they are doing in-office visits as well, and started to resume elective surgeries and started to prioritize those, just like we've been talking about today. So I think the timing of that is, again, specific to the market, but also specific to what services are being provided, and how many different constituents are part of that decision-making process.
Great, thank you. We'll just give it a minute. If there's any other questions, please enter those in there now. Maybe one final thought around value-based care. Where do you see payers or the industry going with the virtual visits? Do you see them reverting back to paying at the level they were at before, or do you see this being adopted as the new level of service delivery going forward?
I think from it's always hard to predict from a reimbursement standpoint. Obviously, from a consumer standpoint, the data is pretty clear. I know that every payer, United Healthcare specifically, their telehealth virtual visit utilization skyrocketed in quarter two amidst the pandemic. I know that a lot of our Optum care practices and other anecdotally just organizations that we've worked with have anticipated virtual visit volumes to comprise anywhere from 30 to 50% of virtual visits, of overall physician visits in the future. So there's quite a turn of the tide in virtual visits specifically, which is just one sliver of the digital health space. In terms of reimbursement, of course, time will tell there, but I would be hopeful and optimistic that reimbursement would follow along with what members and consumers are demanding, and of course what make the economics of making those investments that are happening on behalf of hospitals and health systems to make those investments work. Rob, anything to add to that?
No, I think you covered it well. I guess the only thing I'll maybe quickly wrap up and mention is just that, I think it'll be interesting. I think you'll probably see some overall for reimbursement standpoint. I think you're going to see some providers who are going to try to stay in fee-for-service as much as they can, because that's where, in some cases, there are better profits. But I do think that the COVID has actually enabled people to see that value-based care provides a more steady stream of income for providers, and so that I think there's some opportunities there as well, and that so I can see it kind of going either way. But I'm hopeful that this is a push in the direction of value-based care.
Great, Thank you. Thank you both so much for presenting today and for taking the time. And thank you to all of our Minnesota HIMSS members that joined us today as well, too. Have a great day, everyone.